All for joining us today. I am Andrew Lancey. I am the president-elect and will be the president of Illinois Psychiatric Society next month. I am going to be moderating today, and I want to show my appreciation for those who have done this planning. This is the fourth of our series and final of our series, and you can see that we've talked about neuromodulation, we've talked about psychedelics, we've talked about the TAR1 potential target for schizophrenia drugs. And today we get to talk about cannabis in the legal system and landscape of today and looking at the effects of our patients. So I appreciate you coming today. We have two sponsors. We have Synovian as a sponsor, and we have PRMS, who has also sponsored us. We always appreciate having Rich Stagnato join us, and wanted to give him some time to tell us a little bit about PRMS. Rich?
Hi, thanks, Doctor. For those who don't know, PRMS is a medical malpractice and risk management insurance program designed specifically for psychiatrists. We've been, besides sponsoring this meeting, we're still responsive of IPS as a whole. So it's great to continue working with y'all and seeing a lot of familiar faces, which is nice. With May 11th coming up real quick for everyone who knows, PHE is ending. What does that mean for psychiatry and small extensions here and there? So we do have some complementary information with that information on our website, prms.com/FAQ. Even if you're not sure to our program, there's some information there that we hope is useful there. And of course, with the insurance coverage, we do have referrals that we also do rely on. If you know any colleagues who are in need for insurance, please refer them to us. They can check us out at prms.com, and we have a referral program which pays donations for referring psychiatrists, even if they don't buy the policy. But we do have a lot of good part-time discounts. We cover board complaints on the policy as well. And if you know any ECPs, we have discounts up to 80% first year out of training. So we hope that information is useful. And won't take up too much time. We have people here are not for me; they're here for the talk. So I'll bring it back to you. Thanks a lot.
Thank you, sir. Thanks for joining us and sponsoring us. So welcome. So as I mentioned, we're here to hear Dr. Hinckley speak on cannabis today. So welcome, Dr. Hinckley. Dr. Hinckley joins us from University of Colorado, where he got both of his medical school psychiatry training and child and adolescence training. Prior to that, he had been at the University of Iowa, where he was a medical scientist training program, Brigham Young, where he did his undergrad in neuroscience. And he currently works as an assistant professor at the Division of Addictions Research, Treatment, and Prevention within the Department of Psychiatry, and as the director of the Adolescent Psychiatric Services for Addiction Research and Treatment Services, as well as the associate medical director of the Psychiatric Emergency Services at the University of Colorado Health. He is both co-founder and co-director of the Addictions Biology Lab, and he is appropriately set up to do this talk as they study the development of substance use disorders in adolescents, the interaction between substance use problems and mental health disorders, and particularly how trying to understand the biology of how cannabis use affects the developing adolescent. He's won multiple awards, which included the National Institute of Drug Abuse and American Academy of Child and Adolescent Psychiatry Resident Training Award, and currently has also the ACAP Physician Scientist Program in Substance Abuse Use K-12 Career Development Award. He's co-investigator in an R01, which compares two therapeutic interventions for adolescents and co-occurring PTSD. Since he has the interest in choral music, maybe he'll sing a little bit of this lecture today, so we'll see. Dr. Hinckley, thanks for joining us.
Thank you. It's a pleasure to be with you all today. Singing over Zoom brings back memories of trying to rehearse over Zoom, which was an abject failure, but people still felt it was necessary. So we'll try and forego that experience today. All right, so let me bring this up real quick. Is this presenting okay? Okay.
It looks great. Thank you.
Well, thanks again for inviting me to come. It's a pleasure to be able to talk with you all today. A little bit about cannabis use. We're going to cover a number of topics. By way of disclosures, I do have some research funding. I'm going to show you one slide that has animal data. I try, when I give talks that mix animal and human data, I try and make it clear. As you can imagine, animal data doesn't always replicate in the humans, and they're not really the same as teenagers, although we might think that sometimes. In terms of what I want to cover today, so we're going to talk a little bit about the impact of cannabis legalization, particularly on cannabis products, talk about neurodevelopment and why cannabis use matters, particularly for adolescents and young adults, and hopefully help differentiate that cannabis use during brain development is very different than cannabis use in adulthood in terms of risk that we're concerned about. Talk a little bit about the consequences of cannabis use, touch on cannabinoids as medicine and how that might play into some of these discussions that we have, and then end with a brief discussion of the treatment of cannabis use disorder. So when we talk about legalization of cannabis, obviously this is something that has expanded throughout the United States. When I started doing this work in 2014, this is what the map looked like. Colorado and Washington were the Wild West. Most states had decriminalized marijuana possession, but not enacted laws liberalizing or commercializing it. As you can see, Illinois was an early joiner among the states that did legalize medical marijuana. This is what the map looks like today, and our good friends in Minnesota in the House just voted to legalize recreational marijuana on Tuesday. And so as we speak, this map will likely be changed before the end of this legislative season, at least within a couple of states. And so now you can see that legalization for recreational use has certainly started to expand, mostly on the West Coast, a little bit into the Mountain West, some into the Midwest, and then a large concentration up in the New England area. And so that's generally what we see. There haven't been a lot of states recently that have voted on marijuana legalization and have not successfully passed it. We see a few, but by and large at this stage, most of the time it comes up at the legislature. We're seeing those bills pass. There are only 6 states remaining that do not have any sort of law legalizing possession or commercialization of any sort of cannabis product. So that's kind of the state of where we're at today. So when we talk about putting cannabis use in perspective, how prevalent is it? How much do people use? The prevalence, we have a better idea of. How much people use is actually a very challenging question to figure out. So national surveys still classify cannabis as an illicit drug. So this is from the National Survey on Drug Use and Health. This is sponsored by the CDC. So clearly a federally administered survey, which explains part of the reason that it remains classified in this domain. And as you can see, it is far more frequent than other types of substances that are used that are considered illicit. However, to put it in a little bit more context in terms of, well, what are things that it may be more proximal to? So by comparison, with 49.6 million people having used marijuana in the last year, that compares to about 57.3 million people who use tobacco, about 135 or 138 million that drink alcohol, and about 61.5 million who engaged in binge drinking in the last month. And so, as you can see, the scale of the prevalence of marijuana use is much closer to nicotine, alcohol, and alcohol than it is to any other substance that we see. When we talk about past year use and looking at ages, of course, a lot of interest was given in will legalization result in increased prevalence of use. And this is looking at all comers in the National Survey on Drug Use and Health, with the red triangles being the whole study population, the gray circles being 12 to 17, blue boxes being 18 to 25, and then the pentagons being 25 or 26 and older. And essentially what you see here is that we have seen an increase in the percent using cannabis within the past year. And it's not really driven by adolescence. It's primarily driven in particular by young adults, but also we're seeing increases now among the older adult population as well. In adolescence, there's evidence to suggest that it has remained stable and maybe more recently has come down through COVID, but we're not sure if that's an anomaly of some of these surveys or if that's real. So this is data looking again at NISDA. And what we've done here is we've broken down and compared, well, what about if you've legalized marijuana? So in the case of Colorado, we compared that our state to the Western United States. In green, you have adolescents aged 12 to 17. In blue are their counterparts regionally. Yellow is 18 to 25 young adults regionally, and red are 18 to 25 in Colorado. And essentially what you see is what has been shown in other papers, that states that have legal cannabis tend to have increased prevalence of use both in their adolescent population and in their young adult population. And there's another part to the story. While we talk about adolescents remaining steady, as you can see, the young adult prevalence of cannabis use is increasing. And that's important to remember because they're also still undergoing neurodevelopment. So they're not out of the woods, so to speak, in some of the concerns about the developmental aspects of cannabis use. As you're well aware, the other thing that has come raging onto the market in the last couple of years has been vaping. And teen vaping is no exception to this. 2017 to 2018, vaping nicotine was the highest ever recorded year-over-year rise in substance use. And 2018 to 2019, THC vaping was the second highest recorded year-over-year increase in substance use ever. And so vaping really came on with a bang. And what's important to know when you're working with youth that vape, obviously they're acquiring the majority of their cartridges off the street, off the internet, from illicit sources. And studies have shown they're not actually that great at knowing what they're vaping. They think they do, they'll tell you they do, but then studies that have actually gone and gotten those cartridges and tested them, they're pretty inaccurate in terms of whether it was nicotine or just flavor or THC. Very few cartridges available to youth now are just flavor. So that's what we know in terms of prevalence. It didn't turn out to be as scary as we thought it might be in adolescence as cannabis was legalized. But I don't think that's actually where the most significant potential impact is. I think the most significant potential impact of legalization is actually in the commercialization of cannabis products. So before you had smaller grow operations, typically they would grow the bud and harvest that. They might have an ability to make concentrates. They usually didn't have an ability to do it on a large scale, and they certainly didn't have people with advanced scientific degrees and equipment behind them to help develop these products. This is a dispensary here in Colorado. And with commercialization, this has become a multi-billion-dollar industry. And so now you have all sorts of things that we consider in terms of what are the potential effects: acceptability, canonized medical uses that are typically canonized by legislation rather than by some sort of scientific review process, increased availability, and then the product development. So modes of use have developed. We have all sorts of types of products, and I'll show you some in a minute. Likability and other qualities, that's a big focus of some of the pharmacologic researchers that are working on developing cannabis products. I had dinner a couple of years ago at a conference, and someone joined our table who was from the cannabis industry in Colorado, and he told us that they were working on new ways of combining other substances with cannabis, things that might have stimulant activity to kind of create more of a light switch effect where it would kick in faster, come off faster. And their goal in doing that was, they said they wanted they wanted the user to have more control of the high. But where we went with the conversation is those are reinforcing properties that make substances more addictive. And so you can kind of see how some of the lessons we've learned in the past, we're choosing to repeat those now. So with commercialization came the desire and the ability to really create much more potent products. In many states and for many companies, the percent THC has become synonymous with the quality of the actual product. And so this is looking at national data. This is from DEA seizures, looking at 2008 through 2017. And mostly it was medical back then. 2014 is when Colorado began recreational sales and was the first state to do so. But what you see is even just with medical, in 2009 is when the Ogden memo came out. So many states had passed medical marijuana, but dispensaries weren't really opening because the federal government was still postured to enforce the federal law. And so in 2009, the Ogden memo was released that said that federal prosecutors have been instructed to use prosecutorial discretion to not impose federal law over state regulations when appropriate. So when no other criminality was involved. And then we start to see these rises in potency. And now when you look at Colorado, our average flower is about 20 to 25% THC. And I heard someone from one of the dispensaries say the other day that they have a strain that is now 40% THC, which, obviously we haven't been able to verify, but that would be crazy if they had successfully gotten a strain to produce that much THC. The other thing that comes into play is the THC CBD ratio. As you selectively upbreed THC in these plants, you also downbreed CBD, and also you affect the ratio just by the fact that there's more THC there. And we'll talk in a little bit about why that's important, but the take-home point is THC primarily acts through cannabinoid receptors. CBD acts through multiple receptors, but one of the things it does is it antagonizes the activity of THC at the cannabinoid receptors. And so it's thought that it may actually have some protective properties against some of the adverse effects of THC. So when we talk about other types of products, then what else happened with commercialization in particular is a rise in concentrates. And so it used to be hash oil that we would really see a lot of. After the Ogden memo, you started seeing that become more frequent. It was really kind of around where the blunts were, and then it got up above 50%. Now in Colorado, you'd be hard pressed to find a concentrate that is less than 95% THC. So basically just concentrated it all the way down, and then it can be added into various products. So when we talk about the products that are available, obviously there are the flower-based products. The bud gets smoked as blunts and joints primarily, sometimes in pipes or other devices. And then there are the concentrates. The concentrates are typically used by vaping, edibles. There's other oral formulations. There are creams, topicals, vaginal suppositories, mixers for alcohol and caffeine and food, and then also wax and shatter. So this is basically a hard form of THC or of cannabis concentrate that they have to break apart, which is why it's called shatter. They then flash vaporize it. So what most teens use is they get like a butane torch, which you can order off like Amazon or get from Walmart. And they use that to flash vaporize it, and then they inhale the fumes. I was in a rulemaking group last year with the cannabis industry, and one of the things we were trying to press is what is a serving of wax, and they said ultimately that a serving was half a grain of sand. And I was talking to one of my foster kids, and who dabbed, and I said, "Hey man, I was just in this meeting and I learned that a serving of that stuff is like half a grain of sand." And he's like, "Dude, no way. I do like 2 tablespoons at once." And I'm like, "Dude, I know it's a lot." And so these products are very, very concentrated products. The other thing to keep in mind is the difference between medical and recreational in most states is only in the licensing of the dispensary and the supplier. Some have both, some have one or the other, but the types of products that individuals have access to they're typically not designated as one or the other. It's just the facility itself. That does differ in some states, like in New York, where you cannot purchase combustible cannabis as medical cannabis. And so some states do have some restrictions, but most do not. So when we talk about the other effects that this might have, then the next thing, particularly in youth, is changing perceptions. We have a number of individuals now, youth and parents, quite frankly, who will say to us, "Well, this is natural. This comes from a plant. It's safe." So the perceived risk has really gone down among all groups. It might have been natural at some point, but it's now essentially engineered. It's no longer the wild plant that this was a little over a decade ago. Disapproval has also gone down, not as much as the perceived risk, but essentially meaning that most youth don't believe that they're going to get in serious trouble if they use marijuana or if they get caught. Availability, of course, has initially increased. And interestingly, what this data shows is it has started to come back down again. which is interesting. That may have something to do with some of the policies that are being put in place to try and restrict access, but it's really unclear. I think of particular concern to us as psychiatrists, there was a study pretty recently that talked to young adults who use cannabis. And a lot of the young adults were not able to recognize signs or symptoms of withdrawal or dependence or cannabis use disorder. And many of them felt that cannabis was actually safer than other combustible substances like cigarettes and safer than psychotropic medications, including common antidepressants and anxiolytics that typically get used. And so their perception was, if I have anxiety or depression, it's safer for me to use cannabis than it is to actually be treated. So in the end, multiple studies have shown that there's no correlation between cannabis laws and prevalence. But as I mentioned, there are several other factors at play. And especially with youth, medical diversion is something that's quite common. So the big benefit of medical cannabis in Colorado is it's a little bit cheaper. And so it's something that they often have access to that's getting flipped to them again on the black market when they're purchasing it from friends. And then, of course, the THC potency and the exposure that we see is unprecedented. So let's transition and talk a little bit about neurodevelopment. And this is a twofold story. One, it's an important story to really understand that adolescent cannabis use differs and is important to discuss in different ways than adult cannabis use. But the other thing is the endocannabinoid system itself is expressed very early in embryonic development. And what this slide shows you is that the use of cannabis during pregnancy looks similar to national trends. This paper is a little bit older, but you see overall a slight increase in the prevalence. And that, again, that prevalence is higher in our young adult population than it is in other age groups. That's a particular concern because obviously, given they're in young adulthood, they're still also undergoing neurodevelopment, as is the unborn child. So when we talk about what does the endocannabinoid system do, as you can see, it plays a role in fertilization, implantation, and then it's expressed again a little bit later in development. The cannabinoid receptor is detectable by 14 weeks gestation, and it's very tightly regulated in temporal and spatial patterns. Endocannabinoids, the two that are primary endocannabinoids are AEA and 2-AG. They are basically made and released on demand. Signaling lasts for seconds. It lasts in very specific places. The endocannabinoid system is widely expressed throughout the brain. CB1 is the most commonly or the most highly expressed G protein coupled receptor in the developing brain. The endocannabinoid system itself plays regulatory roles in neurogenesis, synaptogenesis, myelination, axon guidance, and differentiation to what type of neuron it's going to become. It also plays several roles in development of neurotransmitter systems, including serotonergic and dopaminergic systems as well. What we talk about when we transition into adulthood, theoretically after neurodevelopment is complete, one of the primary roles of the cannabinoid system, the endocannabinoid system, is in retrograde signaling, which becomes particularly important when we're talking about long-term potentiation and memory formation. You think about applications to cognitive function as well as to therapeutic benefit for being able to effectively engage and form new memory. It's also involved in neurogenesis in adulthood. There are stem cells in the brain. We aren't great at learning much about them and how to harness them, but they do exist, and the endocannabinoid system plays a role in their activation and development as well. When we look at human studies of use during pregnancy, I'm going to start by saying there are a lot of caveats. There are two major studies that were done that look at this. One was done in Philadelphia, one was done in Ottawa. They were both done basically 70s, 80s, 90s. So at the time these were done, there were multiple confounders. Cannabis was largely considered genuinely illicit. There's a lot of tobacco use and alcohol use within this cohort. And the reason that a number of these women agreed to be in these studies was not because they wanted to contribute to scientific knowledge. It was because they were pregnant and they needed resources. And so the other caveat is these studies tended to focus on socioeconomically disadvantaged individuals. But when we look at what we see, there are some physical issues that come up with prenatal exposure. Primarily what we're concerned about from a developmental perspective are the cognitive and behavioral deficits, as well as impairments in executive functions, such as learning, memory, and attention, as well as increased impulsivity and externalizing disorders. So in these two studies, essentially what they did is they followed these kids every couple of years through adolescence. And this figure here shows you essentially the types of domains that were consistently shown to be effective in infancy, early to late childhood, and then in adolescence. Consistently from early on, we see changes in mood and sleep, as well as impulsivity and hyperactivity, and then impairment later on in developing executive function. And so that's the gist of what these two major longitudinal studies have shown. And that's where the bulk of our knowledge comes from of what happens with in utero cannabis exposure. As teens age and they obviously start experiencing with substances more frequently, the next part of the neurodevelopment question comes, well, what happens if teens choose to use this during neurodevelopment? This is a figure that I really like. And this is the one animal data slide. And essentially what they did here is they exposed a rat model to THC during development, and then they stopped exposing them as they transitioned into adulthood. They ran them through a procedure, which is down green arrow here, which is a foot shock procedure. As you can imagine, being a rat and having your foot shocked induces anxiety and can induce symptoms of trauma as well. And when they did that in these rats, the gray are the ones that were not exposed to THC. The green are the ones that are. The first thing that it showed is if they had THC exposure, they were more likely to develop psychopathology in this particular assay. Break into adulthood, they're no longer exposed. They're now at a pretty steady state of psychopathology. They shock them again. This, I think, is the most interesting part of the study to me. The group that was never exposed, they show about the same risk of psychiatric symptoms going forward. The group that was exposed to THC and no longer is, something has changed in the way that their brain developed. And when they were shocked again, a large subset of them went on to develop worsening psychiatric symptoms after this second time in this assay. What they went on to show in trying to figure out what was going on is that the cannabinoid 1 receptor was dynamically expressed, as was 2-AG, whereas anandamide was kind of like a steady state gatekeeper. And so it was thought that the dynamic expression of these two things and the role that they're playing in neurodevelopment may be what predisposed here. As I mentioned before, the cannabinoid 1 receptor is widely expressed throughout the brain. This shows you some of the domains and some of the functional aspects or psychiatric concerns associated with these. It's kind of like a where's where of potential problems that we might encounter across all of mental health. In terms of what we think the cannabinoid receptor does, especially as the brain develops, it really kind of helps define the axon tracks, what sort of tracks we're going to make, what sort of tracks we're going to keep. And so that's, as you know, fundamental to organizing the higher functions of the brain, such as the cognitive function. What this graph shows here is it shows looking at cannabinoid 1 receptor density, basically. And as you see in gray matter tissue, that density remains basically the same. And in white matter tissue, it precipitously declines through neurodevelopment, basically meaning that as these tracks form, the need to express the cannabinoid receptor in a lot of places decreases. And so that's some of the data supporting that this is its primary role. When you look at neuroimaging, the fusion weighted MRI in heavy cannabis users compared to controls, this in particular here is just a good graphic example. What it's connecting, I don't think is terribly important as much as just getting a visualization of these are individuals who are the controls that don't have cannabis exposure. B, these are the individuals that do. And so you can see the cumulative image between A and B. The axon track in B is much broader than it is in A. It's not as tightly bundled as we would typically see. And so they also saw that there was an 84% reduction in streamline count of the fimbria, and then 88% reduction in the commissural pathways that were extending within this. Younger age of regular heavy cannabis use resulted in decreased myelination, but interestingly not an increase in axons. So axons were still getting cut back. They just were more diffuse, and they were not as myelinated. We obviously have spent a lot of time and interest looking at neuroimaging results in cannabis. That's one of the few ways we have of looking at the human brain and asking what's actually happening here. The one thing to know about cannabis studies, a lot of them are relatively small in the neuroimaging department. There are multiple CB1 rich domains. People look at different things using different algorithms. And so a lot of the findings are pretty heterogeneous. What we do see are trends in specific domains. So for example, cognitive functions like decision-making, concentration, attention, affective regulation, and memory are often implicated across different studies, as well as addiction pathways with the ventral tegmental area and the nucleus accumbens. Some of these studies that look at adolescents have shown that these changes persist with abstinence. In other words, the brain doesn't normally correct it. It does not necessarily correct itself after the teen stops using. But the causal direction of these changes is unknown. That was a big motivation for the ABCD study, which is a multi-institute, multi-million-dollar initiative, basically to conduct a longitudinal study imaging 10,000 kids from 10 to 20. I think these kids are now about 14, if I remember correctly, 14, 15. And one of the goals of that is to look at what's the effect of substance use on the developing brain, hopefully catching these kids before they start. You'll also notice that there are sex differences, particularly in how individuals might present for treatment with cannabis use or what their motivations might be. We know that there are connections between sex hormones, that they modulate cannabinoid sensitivity and the reinforcing effects of drug. One of the places that this really manifests is young women might develop substance use or cannabis use disorder a little bit more rapidly. They also tend to experience more significant and clinically impairing withdrawal, which can make it really challenging for them to get sober, as well as that more rapid progression. So as we transition a little bit then to, well, what are the consequences of cannabis use? I'm going to start a little bit broad and then focus into mental health as we talk about this particular issue. One of the things that we are most concerned about or most interested in better understanding is what are the functional impairments? What are the changes in executive functioning, memory, concentration? There are some differences in motor coordination, which obviously comes into play with these fellas here with driving. And concern around the impact on driving, as well as there was a study that showed that there was a decrease in IQ, which was later supported and replicated. We know that adolescents are more susceptible to the negative functional impairments of cannabis. We believe that's because of brain development and the role of the endocannabinoid system in brain development. We also know that association with early age of onset and quantity or frequency of cannabis use is also a factor when looking at these functional impairments. So in talking about the impact on mental health of cannabis use, the prevalence of mental health disorders is higher in individuals who misuse cannabis. That's true across substance use disorders though as well, but it is higher in those who misuse cannabis. Severity of cannabis use disorder and comorbid mental health disorders correlate. Part of that may be due to the fact that there's overlapping symptomatology. So states of intoxication and withdrawal can look like other psychiatric challenges. For example, we can have a motivation, which can look like anhedonia. In withdrawal, we can have quite a bit of insomnia, profound states of exacerbated anxiety. And so we definitely see overlap between these conditions. There's also some evidence to suggest there may be common neurobiologic etiology. In other words, some of the pathways that mediate the development of psychiatric disorders are also affected by cannabis use and may mediate the pathways within cannabis use disorder as well. And then there's this model of shared vulnerability, meaning that the risk factors and the predisposition to having a mental health disorder are sometimes shared with the predisposition to use cannabis or develop a cannabis use disorder. That gets balanced with what's called the self-medication hypothesis in terms of why these correlate together, which suggests that many individuals might use things like cannabis to self-medicate or self-regulate their affective state in particular, or their anxiety. And we'll talk more about that here in a little bit. We do see lower rates of treatment engagement and compliance with treatment, which may be part of why severity is correlated and part of why they have a worse clinical outcome. In terms of the consensus of the impacts of cannabis on mental health, there are two general things to think about. One is what's commonly comorbid with cannabis, and we don't know that cannabis directly has an impact on that so much as we know that they commonly co-occur together. And then where do we see associations where we think that cannabis might actually have an impact? So with the comorbid psychiatric disorders, obviously the externalizing disorders are very common in youth in particular. There may be some inattention that can be caused by cannabis use. Major depressive disorder and generalized anxiety disorder are also the most common comorbid disorders we see. In terms of associations, we see worsening of anxiety, psychosis, and there's twofold parts of that, and I'll talk about that in a minute. Schizophrenia, early onset of bipolar disorder, increased risk of suicide attempts. There are not a lot of things that positively predict suicidal behavior. Active problematic substance use is one of those things. And so definitely something that we flag and encourage people to flag in terms of risk stratification. Lower levels of social functioning in comorbid schizophrenia. And then as we saw before, increased relapse to substance use and then non-adherence with their psychiatric treatment recommendations. Particularly in youth, we see a 5-fold higher prevalence in mental health diagnoses and cannabis-associated ER visits. Within these cohorts, we also see that schizophrenia spectrum disorders are about 9 times more common among youth who use cannabis, and prevalence of self-inflicted injury within these youth seeking emergency care is about 8 times higher. Overall, across what we understand of the total population, over 30% of adolescents and 80% entering treatment for substance use have a comorbid psychiatric disorder. So generally, by the time they're getting to us, the general rule of thumb is they likely have a comorbid psychiatric disorder. I want to flag 2 particular mental health issues that I think are of most concern and most significant. One is this concept of psychosis. So a lot has been discussed recently about cannabis-induced psychosis. Is it a thing? What is it? What does it mean? And the way that I think about this particular topic is cannabis, as with some other drugs, does seem to be able to induce a psychotic state, meaning that it can trigger that. The question is that because they have underlying biologic etiology that allows them to become psychotic, such as those with a family history of psychosis? There are cases where we have no known family history, so we don't fully understand that. The primary risk factors are the potency of the THC, the duration of their use and initiation at a younger age. So a lot of studies that first started exploring cannabis-induced psychosis were done in Europe. In Europe at the time, 10% THC was considered high dose, and was called skunk in a lot of those papers. And so, as you can imagine, there's nothing in Colorado that under the initial definition of high dose would be considered low dose. And so these are all pretty high potency products. Clinically speaking, when we see a case that we think is cannabis-induced psychosis, the general narrative that we get is that this is someone who may have been using but had a sharp increase in the frequency of their use, typically concentrates, most often dabs or vape pens or other concentrates that they're using, very heavy period of use, usually for a week or 2. And then within that period of use, a pretty quick transition to psychotic. Usually a day or 2. And so it's not like there's this long prodromal phase that we see develop. And then in abstinence, typically we see that resolve. In kids, there are some cases where it does not resolve. We don't fully understand that. And then the second part of this is cannabis can exacerbate underlying psychotic disorders like schizophrenia. And our experience with that is it tends to look like schizophrenia, just maybe clinically worse than it would otherwise. But you see kind of that prodromal phase. And then, you see kind of the typical course, but maybe a more severe course of schizophrenia. The second thing that I wanted to highlight in terms of risk is suicide attempt. This is a study that we recently published. This was done in the National Comorbidity Survey Adolescent Supplement, which was a national epidemiologic survey to look at factors that contribute to the development of mental health disorders. The reason that this was nice is because it included cannabis use, with both lifetime use and past 12-month use. And it also included depression, but not like a standard, do you have depression? Yes, no. This actually had a valid diagnostic construct that looked at severity based on functional impairment and overall symptomatology. And essentially what we were able to see here, when you look at lifetime suicide attempt and lifetime cannabis use. So this model presents these various factors controlling for all of the others. So after controlling for sociodemographic factors and controlling for depression itself, adolescents who had ever used cannabis were 6.9 times higher, had a 6.9 times higher odd of ever having a suicide attempt. As you can see, both mild to moderate depression and severe depression after controlling for cannabis use were also significantly associated with suicide attempt, as you would expect. When looking at past 12-month, similar type of model, this time looking at major depressive episode in the past 12 months as well. what we see is those that had used cannabis within the past 12 months had a 3.7 times higher odds of having a suicide attempt. And this is compared to about 8 times higher odds for those that had mild, moderate, major depressive episode, and about 36 times higher odds for those that had a severe major depressive episode. When we looked at the frequency of past year use broken down as less than monthly, 1 to 3 days per month to 1 to 2 days per week, and then 3 or 4 days per week or more, we see this kind of emerging dose effect where the adjusted odds ratio of having a suicide attempt goes up as the as the frequency of their substance use goes up. There are some socioeconomic consequences that are fun to think about, not necessarily maybe all that relevant, and certainly won't deter use. But again, as we look at the pregnancy studies, the other thing to consider here is a lot of these were done in the 80s and 90s as well. And so there's an outstanding question in my mind, these socioeconomic consequences. Are these driven by marijuana use, like a motivation or cognitive impairment? Or similar to some of the pregnancy studies, is it the social context in which the marijuana is being used that may be associated with some of these factors? So what can we tell patients? NIDA has published some guidelines. This is National Institute on Drug Abuse, has published some guidelines looking at their synthesis of the evidence in terms of acute consequences that are particularly of interest to us: impaired attention, judgment, and other cognitive functions, anxiety, paranoia, and psychosis. In terms of longer term effects and the level of confidence, addiction to marijuana and other substances, diminished lifetime achievements, abnormal brain development, progression to use of other drugs, schizophrenia, and depression and anxiety are things that come out as having some sort of medium or high level of confidence as far as downstream effect of cannabis use. When we talk about adolescent cannabis use and what that might mean in young adulthood, daily users of cannabis before age 17 are less likely to obtain a degree or complete high school. They're more likely to develop cannabis use disorder, use other illicit drugs. And again, you see this risk of suicide come up in this study cohort as well, adolescent exposure looking at young adult suicide attempts. All right, so that was kind of a whirlwind. But let's touch base a little bit on cannabinoids as medicine. It's important, I think, to have a grasp of this topic because this is one of the few drugs that our patients will use that will tell us something to this effect. Weed is the only thing that helps me do any number of things. Oftentimes when we see this, we tend to think of this Scottish castle, right? They're putting these walls up. How are we possibly going to get through? How are we going to get around this? And you know, there are some things to consider here, and could it help with some of these things? The thing to remember though is while we're thinking of the castle, the majority of our patients are actually more in this state. Weed to them really is the life raft or the life vest that kept them afloat through their PTSD, through their anxiety, through whatever it was. They have a lot of fear of giving it up. Abstinence can be scary. Going through withdrawal can be miserable. And so I think sometimes if we can just change that initial focus and have empathy for what they're going through, that can help facilitate the discussion a little bit more. When we're talking about cannabis as medicine, there are several types of cannabinoid products. A lot of patients who might say that to us are using what they get from dispensaries. So they're broad spectrum products that usually have high concentrations of THC, relatively low concentrations of CBD. In addition, there are FDA regulated pharmaceuticals. Dronabinol is THC, Epidiolex is CBD. There's also, as we mentioned, or I guess I haven't mentioned it yet, the hemp-derived products. So hemp, by definition, has a low level of delta-9 THC. The caveat to that is delta-9 THC, as is implied by the number, is only one of multiple other THCs. And what we have seen recently in these hemp-derived products is they can't have delta-9, but they're not regulated. And so they can have any other number of delta THCs. We've particularly seen upreading in delta-8 THC and delta-10 THC to the point where there have now been a few cases nationally where we believe it is a delta-8 THC induced psychosis that has been observed, and that has had to be treated. And so we are starting to see some of these hemp-derived products actually look more like the recreational products, just a different form of THC that was considered a minor cannabinoid in the natural plant. There are some potential medical uses of cannabinoids, particularly on the THC side. The majority of the evidence is with pain. There's also a lot of interest in looking at its anti-inflammatory properties. And then with CBD, a lot of the early research has looked at seizure disorders and other neurodevelopmental disorders. We have studies at Children's going on, looking at Prader-Willi syndrome, looking at autism. So a lot of use potentially there. And then there's some evidence for other diseases, but nothing that has been considered definitive or likely to have evidence. As I mentioned before, CBD and THC are very different. So whereas THC focuses on this endocannabinoid system, and this is where it mediates its effects, this is what we know so far about where CBD mediates its effects. So within the endocannabinoid system, but also dopaminergic system, GABAergic systems, serotonergic systems, HPA axis, so multiple systems that interact with what we think are involved in psychiatric disorders. When we look at specific receptors and the potential pharmacologic outcomes, one of the interesting things about CBD in particular is it may have some anti-anxiety properties. It may also have some antipsychotic properties. And so that's where that potential risk comes in terms of the high potency products, having less CBD to potentially counteract that. There have been studies looking at CBD as an antipsychotic. As you can imagine, it's not an adequate antipsychotic. So no one, I don't think, is going to start putting everyone with a psychotic disorder solely on CBD to treat that. In terms of the growing consensus among people who are looking at these things, there's a difference in risk benefit between CBD and THC. So if I have someone who's really, really set on using cannabinoids for whatever reason, can they have a conversation about what would it look like to bring down THC potency, increase CBD, or potentially switch to a CBD primary product? And that would certainly potentially change the risk profile. As I mentioned, CBD may be useful in some aspects of psychiatry, particularly in insomnia and anxiety. Those are also two things that people really struggle with in cannabis withdrawal. Studies that have looked at CBD for cannabis withdrawal have not shown that it's helpful, but certainly somewhere where we can potentially change some risks. There are ongoing studies looking at CBD for opioid use disorder, PTSD, and depression as well. But ultimately, the consensus is we need to understand more. A lot of researchers that are on the medical side, though, when it comes to things that overlap with mental health, the primary compound of interest is CBD. In terms of evaluating cannabis use in our patients, I think it's really important not to dismiss what they say when they say this is the only thing that helped them. Don't take the castle view, take the floating dog view. Try and understand where they're coming from, what their experience is. Sometimes it's helpful to use validated measures to really get an idea of their mental health, show them something objective, get an idea about their cannabis use and the timeline of how these two things correlate with each other. Studies show it doesn't really matter which one comes first, depression or cannabis use, anxiety or cannabis use, that's not really important. But it can be helpful in terms of helping them gain insight into their own mental health. It's important to consider cravings and withdrawal and explore those. And then particularly highlight and identify times when cannabis didn't help them. So they may not be willing to give up their cannabis for anxiety, but they may be willing to tell you there are times when cannabis does not work for my anxiety. And then you can say, well, why don't you save yourself $10 and let's see if we can find something else that might work during that time. And so that's a strategy we'll often use in people who really don't want to cut back, but serendipitously they may cut back as we help improve their anxiety, entering it through a less threatening, less direct door for them. And then we can propose experimenting with abstinence or decreasing use. You can decrease potency, you can decrease quantity, and you can decrease frequency. And so all three of those matter. So if someone's willing to give up dabs and go to smoking blunts, I'll take that as a victory in the moment. That's great. Let's do that. Let's see where you're at and let's keep going. So then briefly talking about cannabis use disorder and how do we treat cannabis use disorder. As I mentioned earlier, there's some real lack of insight into cannabis being a problem, cannabis being addicted, cannabis being associated with other sorts of issues. Because of that, it's imperative to really consider motivational interviewing and how we approach this, how we bring these topics up, how we move people towards change. And so thinking about exploring their goals and their values, open-ended questions, all these kind of skills that we learn in terms of affirmations, reflections, and summaries, exploring the pros and cons of use. This also gets at, it allows them to feel safe telling you cannabis helps me sleep, and that you're not gonna ridicule them or become paternalistic with them, but you're gonna hear them out. And creating a space for them to do that by saying, "Hey, how does cannabis help you? Are there things you don't like about it? Are there ways that it's caused harm for you?" Incorporating that talk also then becomes really valuable in terms of creating goals, in particular with adolescents and young adults, but also growing increasingly with adults in cannabis use. Abstinence not necessarily their goal. It may never be their goal, but you can find other ways to help decrease their risk in what we would consider a harm reduction approach. Ultimately, when referring adolescents for substance use treatment, most of us would tell you certainly you can refer pre-contemplative adolescents. I know of a lot of cases where someone said, "Well, we didn't refer them to you because they're not interested in changing." It's like, well, that's what our job is. Our job is to help them get there and help them develop that insight. Psychotherapy is the mainstay of treatment across age groups. So motivational enhancement therapy combined with CBT and contingency management. Acceptance commitment therapy is being explored as a potential strategy. For adolescents, there are family-based interventions as well. So when we talk about, well, why don't kids get sober, or why don't adults get sober for that matter? These are the major things that come up. Lack of insight. So they may not recognize that they've lost anything due to their substance use. There's this concept of substance-related losses. If they don't see those losses, it's hard for them to say, "This has done me any harm." That's one thing that we can work on exploring with them and trying to develop, and a place where collateral might also be of use. A loved one, a family member, someone else saying, "This has really cost them their job. They don't go out anymore." Starting to discover what are some of those losses. People who have insight into substance-related losses are much more likely to engage in treatment and want to change. Perceived benefit related to cannabis use, we touched on. You don't see a lot of people telling you that other types of substances only help them. They all have positives. Even people who use methamphetamine, cocaine, other types of drugs, they'll identify positives of their drug use. It's not all negative, but they generally don't tell you that they think it's safe, or it's the only, it's the only thing that's helping them. We also see a lot of acute withdrawal and craving. This is particularly true with high concentrate products. In my experience in trying to get individuals sober from using high concentrate products, this is right up there. We have more kids get sober from fentanyl than we do get sober from high potency THC products. It's a real challenge to get there, and the withdrawal can get pretty bad, particularly with the insomnia and the anxiety. If they have those two issues and we don't effectively treat them, they really stand very minimal chance of maintaining any sort of sobriety. And then, of course, the worsening comorbid mental health conditions. If they start to quit and their mental health starts to get worse, which we would expect, that can also be reinforcing to use and make it less likely that they're going to try and quit. One important thing to remember in thinking about substance use, a lot of times when people begin using, they use essentially to get high. And so what you see on panel A, these are drug naive individuals looking at the dopaminergic and GABAergic pathways, as well as the opioid system and the nucleus accumbens. And what you see is there's this big surge in dopamine signaling, basically. That's the rewarding effect. It's the high effect. The negative reinforcement, the feedback is pretty minimal. It's not nearly as high. As they transition into chronic use and the brain undergoes changes due to the level of use, you see a reversal. That positive reinforcement, that dopamine surge, is less profound. But now what's really profound are the mechanisms the brain has put in place to stay functional and survive. And that leads to a lot of negative reinforcement. In other words, a lot of symptoms. So it's not uncommon for people to transition from using to get high to using to avoid getting sick. And that's a very different approach in terms of just stop using. You tell someone who's using to avoid getting sick, just stop using. What they're hearing is just get sick. I want you to feel worse. And then in the end, you'll feel better. We also see cyclical patterns of impairment, particularly with PTSD. And so there are these patterns of hyperarousal, intoxication, that leads to withdrawal, which looks a lot like hyperarousal, and they use again, and they can get stuck in this downward spiral. And so in particular, when we're talking about trauma disorders it's really important to find the balance between trauma and substance use. It usually won't work well to tell someone who has significant trauma, you have to get sober before I can treat your trauma. We would expect that their trauma disorder is actually going to get worse in those types of situations. It's something where they may not have a lot of skill. This is like the epitome of the dog that's in the life vest. This is what kept them alive as they struggled with their trauma. There have been a number of studies looking at medications for cannabis use disorder. These are all off-label. There's nothing that has an FDA indication for cannabis use disorder, either for cannabis withdrawal or for the treatment of cannabis use disorder. There are a number of drugs that have been considered in withdrawal. Some have shown potential positives. If we start with the cannabinoid type drugs themselves, there are 3 studies that show that dronabinol might be effective in reducing global withdrawal symptoms. Most of these studies are done at pretty low doses, and so they're mostly equivocal. There's currently a dronabinol study going on that's using significantly higher doses, like 10 times higher doses. And that study does seem to be showing some positive effects. Nabilone and nabiximols also showed some encouraging data. Nabiximols no longer being available. Cannabidiol, as I mentioned, really didn't pan out to have a role. Other psychotropic medications that can be considered, naltrexone. There are 2 studies showing that it may reduce long-term use. N-acetylcysteine has been shown to help reduce cravings in adolescents, but not in adults. My experience with N-acetylcysteine, if we start it in youth, it works or it doesn't. If they tell me a weekend it's not working, there's really not much of a reason to keep it going. I've seen that they pretty quickly know, yeah, it's helping my cravings, or no, this does nothing for me. There's really no harm in continuing it if you want to continue it longer, but you'll usually know pretty quick. And when I talk to them, I pitch it as this will work or it won't, but it's not a drug we're going to increase the dose of. Gabapentin has also been shown to be effective in some cases. While gabapentin itself is not has not panned out to be all that helpful for psychiatric disorders, this may kind of be a niche where it can be helpful, particularly in individuals that have a lot of anxiety and insomnia. Sometimes giving them gabapentin at night can help them reduce their cannabis use and can also help prevent withdrawal, worsening those things. And so that's one way that we do use this sometimes off-label. There are other studies that have looked at topiramate, zolpidem, which obviously there are concerns about using zolpidem in a substance using population. Mirtazapine, particularly looking at insomnia and loss of appetite with discontinuing use. Quetiapine as well, one that showed some benefits in withdrawal, mostly studied at lower doses. There's currently a study going on looking at more like antipsychotic doses in the 300 to 600 milligram range. And my understanding from the people conducting that study is it does show promise. And they would argue that the harm of being on an antipsychotic dose of quetiapine for a couple of months is probably less than the harm of continued cannabis use. So that's kind of the argument that they use and why they do this. But obviously a lot of things to consider and balance in considering what medications might be useful. To finish up, best practices for treating comorbid mental health and cannabis use disorder: comprehensive diagnostic evaluation, clinical evaluation, really try and understand the connection in their experience and in their words between their cannabis use and their mental health. And quite frankly, if I'm being a little blunt, I know I'm being recorded, so I hope I don't get in trouble for saying this, that actually may be that some small degree of cannabis use, they actually function better than if they stopped using cannabis altogether. In other words, there are now some evidence to show that it's a U-shaped curve. You use a lot of cannabis and your mental health gets worse. You use a little bit of cannabis and it might be better than no cannabis at all. And so how hard are you going to fight to get that last joint? I wouldn't tell people, oh yeah, use weed, it'll help your anxiety. But when you're treating these patients, how hard are you going to fight to get them to abstinence, or are you just going to try and get them to remission? And I think that's really important to consider. Using baseline measures, psychotherapeutic interventions are first line, but can certainly consider psychotropic medications, particularly in the moderate to severe illness, when they have significant functional impairment or when they're not showing improvement with the therapeutic interventions. In conclusion, cannabis is changing, particularly with commercialization. Our biggest concerns now are with potency of the products that are available, modes of use, and risk perceptions and how that impacts treatment. The endocannabinoid system is fundamental to brain development from conception through young adulthood. Prenatal cannabis exposure has its own executive function problems and downstream mental health problems, but then adolescent cannabis use is also associated with executive function and mental health problems. In adulthood, we see some exacerbation and association with worsening mental health, but because brain development is completed, we think of it being less common in causing those types of developmental or cognitive problems. And then again, psychotherapy is the mainstay. So with that, I'll turn it back over and I'm happy to take any questions.
Thank you, Dr. Hinckley. It was a wonderful talk. It's really nice to get a talk that's that aligns with my clinical practice when it comes to cannabis, because oftentimes I'm arguing. But this was a great talk because it does confirm a lot of the things that I try to teach in my residency as well. So I appreciate that. So for questions, if you want to put questions in the chat or raise your hand, we can